Miller. Don?
Yeah, Donna Miller.
Donna Miller.
Okay, so that's the third one. So, Keith just told me the years fly by. I remember when he moved his practice to LeGrand, which was 25 years ago plus. Yeah. And Janet retired, and she worked with Winding Waters Clinic for years and did this kind of work there. But Keith was a GP here first, and then in LeGrand. Pardon?
I thought it looked familiar.
It's the great
Anyway,
beard, right?
so they've been working on this together and kind of from different ends of it, because of course Keith has had patients over the years in these kinds of situations, and Janet has worked with patients in her role at the clinic. So I'm just going to turn it over to them. So this is a brief introduction, I think, an introduction to this.
Yeah, and I'll pass these out. Originally, I was gonna say, these are rare now because the publishing company is out of business.
Yeah, for sure.
Oh. Okay.
I
You've
grabbed
got
it. I
one?
grabbed it.
And Nancy, do you want one to just follow along
Sure.
with? We've done this together, which is how this happened.
Janet, is this the same?
I don't know, but you get your own booklet.
Oh, I do? You do?
Anybody else?
Yeah. Your life
I think I'm getting old enough.
Well, whoever is responsible for you will love you for it.
They're handy.
Okay, so I guess I'm going to do an introduction. This is what we had planned to do today is kind of tell you why you need an advance directive, and that's kind of Keith's job from his experience, 40 years almost as a physician, internal medicine, so this is his wheelhouse. And for me, as a mental health person, what happens if your family doesn't have the information they need at the most stressful time in their lives? And so this is a gift to them, and it's really important that we tell as many people as possible that this is relatively easy to do and very reassuring when you finish the process, because it's done, and it can always be amended, you know, as you get older and things change, but at least you have instructions and you've talked about them with your loved ones. So today what we want to do is just go through experience that Keith has had and why it's important, and kind of show you the 3 sections of the booklet and explain them, but we don't have time to go through and do this. It's a real process to fill this out, and you need to do it, I think, in a group so that you can bounce ideas off each other and you can ask questions, and if you have a medical professional there, it's really helpful because it's like, well, what does it mean? Do everything. This is what it looks like. So we'll go over that a little bit, and then what we'd like to do, if any locals are interested, we're going to do a 2-part workshop. The first part will have a discussion on the advanced directives, scenarios, you know, what the language is, how you should be thinking about it, and in an intimate setting. And the second part, then, after you go home, think about it, fill it out. It's a worksheet, so it's not final. Just fill out the worksheet. That's part 2. And then we'll come back together and fill out the actual advanced directive and help each other sign it and make it legal. And so it's a 2-part workshop, 2 hours probably each part. And, you know, we'll pick a place where we can have some desks and beer. Really, you know, there isn't any reason not to have a beer while you're doing this. Love it.
Well, let's go with Randy Road.
Okay. Yeah. JC will let us come. Nancy has a little experience with doing this. She was going to just say a few words. She's part of our team, and so she'll be helping to set up workshops and help us manage workshops. And
Kind of have said I'll be available for whatever it is they need. Just a little testimonial. Probably 5 years ago, I was, doing my annual physical at Winding Waters, my primary care person said, "Do you have an advance directive?" And I'm like, I have had that booklet in my inbox on my desk for at least 3 years. And every time I look at it, I find something, including vacuuming the rug, that is much more important to do. Or at least I would prefer to do. And I hate vacuuming. So I just knew I wasn't, well, I just had this big, I guess it was a psychological hurdle to doing this work. And she, my primary care person, said, "Gee, we have someone on staff here who can walk through that with you. May I schedule that?" I said, "Absolutely." And it was Janet. She and I spent about an hour, hour and a half walking through the process, and I'll tell you, all of my apprehension about it melted away. It was, we had fun. First of all, I got to know her a whole lot better than I did. We knew each other previously, but only kind of superficially and socially. So I got to know her much better through that. And it was just so very helpful to me. About 6 months before COVID, Keith had retired. Janet had been wanting to kind of spread the word about Advanced Directive. Keith wanted to join her in those efforts, and I offered to put together a little group to work on Advanced Directives together. We did the first half of this workshop before COVID, and then COVID struck. So we've actually, almost everyone in the group has completed their Advanced Directives, but not with the Part 2 workshop because we couldn't gather. But I just want to tell people that it is, number one, uber important to have it. But secondly, that working through it with others, and particularly with professionals who understand the language and understand the apprehensions that come along with the process, but also understand the benefits so clearly, is extremely helpful. So with that. Okay.
Well, Nancy used the word psychological hurdle, and I think that's a very apt description. I think most people actually don't really want to talk about a medical crisis or facing possible death. I think it's understandably difficult for most people to talk about it. People often have great intentions to have an advanced directive, but when push comes to shove, they just don't get it done.
Can you guys hear? Everybody hear? Okay.
I'll try to speak louder. As a primary care internist, actually, not a general practitioner, but 6 of one, half a dozen of the other, my practice largely revolved around people with complicated medical illnesses, chronic illnesses, and a lot of people at the end of life. I had a very, very elderly practice, and so I sat at many a bedside, many a long night with patients in the hospital who were gravely ill. Advanced directives make it easier for everybody. It certainly makes it a lot easier for the physicians or the nurse practitioners or whoever is taking care of you. It makes it easier for you because you don't potentially get treatment that you don't want, life-sustaining treatment that can keep people alive for long periods of time, beyond any real hope of recovery. Medical science has progressed to the point where we can keep people alive for years. I think about the Karen Ann Quinlan case, the Terry Schiavo case, with feeding tubes and the advances that we have. People can basically be functioning on a very, very basic brain level and stay alive for years and years and years. And most of us don't want to even think about, being kept alive like that. I think in the 38 years that I practiced, I think I really saw a shift in people because as a young doctor, people always just said, just keep me alive no matter what, doc, and it was, and that was kind of the standard position that most people had was whatever you do, doc, keep me alive, And I think culturally we underwent some major changes over that 38 years, and a lot of people started to think about it and think, I don't think I want to be kept alive if I don't have a quality of life. And so as time went on, and as as my practice matured, and I took care of more and more people that I'd taken care of for many, many, many long years, I had the experience of seeing a lot of them during very grave medical illnesses, prolonged illnesses, sometimes and increasingly as they got older, resulting in death. And so I saw a lot of what I would consider to be terrible deaths, and I've seen a lot of really great deaths. And I think sometimes people wonder, well, what's a good death and what's a bad death? But I saw that indiscriminate application of medical knowledge to keep people's bodies alive is really results in a lot of very sad scenarios. And so Oregon was the first state, as far as I know, to come up with a PULSed form. You've probably heard of PULSed forms. It used to be called Physician Order for Life-Sustaining Treatment. I saw it's now referred to as a portable order for life-sustaining treatment. But each state has their own medical boards who decide who gets to be licensed, and Oregon was, I think, the OHSU Center for Medical Ethics was the one that came up with the PULSed form. And that's an order the physician signs that says you do or don't want CPR, you do or don't want to be on a ventilator, or you do or don't want to have a tube feed. And as soon as the physician signs it, it comes into effect. An advance directive is an entirely different document which lays out in a lot more detail what your wishes would be in the event you can't communicate. Now, some healthcare providers are really good at sitting down with their patients and encouraging them to do an advance directive. I've heard physicians whose entire discussion set was something on the order of, if you die, do you want us to bring you back? That was it. I mean, not a lot of detail, not a lot of nuance. So I never bothered with the PULSed forms unless people were being basically admitted to the hospital, because that's when you really want to know if they have a cardiac arrest or a respiratory arrest, are you going to do CPR or not. The advanced directives, I think, have a much broader application for anybody that is older, for anybody whose chances of undergoing a grave medical crisis are increasing, for anybody who's got a chronic illness that may result in a deterioration of their quality of life. It's good to address these forms in detail. I think some of my worst experiences as a doctor were in patients who did not have an advance directive and then never discussed it with their families. And the scenario that would typically present itself is somebody's had a heart attack, somebody's developed pneumonia, they're in respiratory failure, they're gravely ill, they come to the hospital, they're sedated, they're put on a ventilator, and then you start trying to figure out what did the patient want to happen in a scenario like this. And if they had not had an advance directive filled out in advance, typically there's not a lot of opportunity in a lot of these cases to do that while they're in the hospital. and it falls to the surrogate decision makers to come up with, you know, a strategy for managing this illness. And I think I blanked out a lot of those experiences because they were so distasteful, disturbing, and stressful and frightening for everybody. And you know, the worst case scenarios were when you had half the family saying, Dad would want everything done, and the other half saying, Dad wouldn't want any of this done. And it's really an impossible situation. I mean, a lot of times, as the physician who's actually writing the orders and making the decisions, you're totally stuck. I mean, there's no way to work it out. You can't. So the hospital ethics committee should be able to step in if they have one, if it's a hospital that has an active ethics committee and does consultations. I headed the committee at Grand Run Hospital for a number of years. And if anybody on the healthcare team or the patient's family wanted the ethics committee to step in and try to sort through it, it was a big help for the provider who was trying to write the orders and decide whether or not to do this intervention or that intervention, or whether to let the patient die, you know, naturally. So advanced directives can shortcut all of that trouble. When you work through this, you've got these worksheets where they present you with a bunch of different questions like, well, in the event of this, would you want this done, or would you want that done, or would you want nothing done, or, you know, and so it forces you to really think about it. And I think working in a small group, you can dialogue, you can, you know, people will bring up anecdotes. My father or my uncle or whatever went through this, and this is what happened to them, and I want to really avoid that kind of situation. So it's really helpful to, as much of a psychological hurdle as it may be, to look through it, read through it, discuss it, and then come up with your basic guidelines. And those guidelines, you know, in the event that you're not able to communicate, are going to be invaluable to your healthcare provider and your family in helping make those decisions, because every case is different. There are no two identical cases. And so you have to look at all the nuances in any case and say, well, here's the decision we're facing now. You know, do we do this intervention, or do we stop this intervention, or whatever? And these are the guidelines that will allow your surrogate decision makers and your healthcare provider to navigate your body through this crisis. So I am a huge fan of advanced directives, and I'm a huge fan of people sitting down with their loved ones who will probably be in the decision-making seat if you are gravely ill and can't communicate. Now, if you're in the hospital and you're awake and alert and mentating normally, the doctor or the nurse practitioner should always ask you, what do you want to do in this situation? Lay the facts out. Here's what we're facing. You know, do we put you on a ventilator? Do we start this treatment or whatever? And I've been surprised at times in the past when I heard physicians saying to the family, well, what is your dad or your uncle want here? And it's like, well, the patient's awake and alert in the room. That should be a discussion in front of them, not with the family over here. So as long as you're communicating and mentating normal, you're not delirious, the doctor should be sitting down with you and saying, here's the situation, here's some decisions. But in case you're uncommunicative, that advanced directive needs to be available to your provider and to your healthcare representative. I've often said that I think the most important part of the advanced directive is your designation of your healthcare representative. because you can't possibly game out every possible scenario for what's going to happen. Your healthcare representative, your spouse, whoever, is going to be asked questions potentially. What do we do here? You know, so there's the list on page 27 of the booklet of the surrogates that
Does everybody
and
have them?
and the order that the doctor should go in if you don't have an advance directive. So if you show up at the hospital, you don't have an advance directive, now you're on a ventilator, we're trying to cure your pneumonia, and I'm talking to the family, I'm first gonna talk to the spouse. It says guardian, but most people don't have a guardian. So it would be the spouse first. If the spouse is unavailable, then it would be the children, or if they're not available, then it would be the parents. If they're not available, the siblings. So there's a rank of priorities in terms of surrogate decision makers, but your best bet is to have a healthcare representative designated in your advance directive, have those worksheets filled out, which covers a lot of different case scenarios, so that the healthcare representative can look at this and say, here's what they wanted, and here's what they said they wanted, and so we're gonna make the decision this way. And it just makes everything work better. It makes for a smoother navigation of the crisis, and it takes a big stress off your loved ones if you have your wishes, your values spelled out in an advance directive.
So do you want to take time for questions now? The next step and then final step here, excuse me, is to just quickly go through this and explain the 3 sections, so you know exactly what this booklet is about. We would hope that you're interested in a workshop, but if you have the sense of really what you want and you can fill this out yourself, just take it today and do that. Our goal is that everybody has one of these. So if you're not interested in a workshop in September, then please do this on your own and follow the instructions. If you just read it carefully, you'll be able to do it on your own. But it's really nice to kind of stir the pot with other ideas and stories before you do this.
And is there like a statewide repository where you put these, where they're all digital, or is it just in a filing cabinet at home?
You know, whoever you send this to will have it, but I don't think there's a state.
As far as I know, and you know, I've been out of practice for 3 years, so it might have changed. The post forms, the physician's orders, there was an electronic registry, so that if you had a post and you were out at some reservoir fishing and you fall over from a heart attack, the paramedics could actually access that post form on the state registry. But I don't think there's a similar thing for the advance directive.
I'll put this on my Facebook page.
Well, here's my suggestion, because I couldn't even tell you the number of times that I had somebody come in the hospital and I say to the family, gee, did they have an advance directive or anything? And they go, yeah. And I'd say, well, where is it? Well, it's in a filing cabinet at home. And it's like, well, you know what? We need it here. So what I recommend is that people make copies of this, give a copy to your doctor, give a copy to your hospital, and give copies to your healthcare representatives so they have them to look at. And that way, you know, if something terrible happens in the middle of the night and they have to get a hold of your healthcare representative, the healthcare representative can say, I've got the advance directive right here. And so, you know, you want it as widely known as possible so that you don't face a scenario where the family's standing around the hospital going, yeah, they have an advance directive, but we have no idea where it is.
The other thing to consider is that this is going to be the most stressful time anyone really has in their life. When they're going to the hospital because a loved one has had an accident, has an illness, has, you know, had a stroke, heart attack. These are not normal times where your brain is thinking correctly. These are crisis times in which the stress has a tendency to really mangle your thinking. And so this clarifies it for everybody. You don't have to think back to conversations you had. What would you want? All you have to do is pull this out. You know, he told us what he wanted. So, let's just go.
You know, it really would make sense though. I was just looking at who prepared this, Oregon Health Decisions. That's a nonprofit, it looks like, because it's .org. So,
Yeah.
and whether they have a registry, but it really would make sense to have some kind of a formal
Yeah,
way to
I haven't called
distribute.
them.
I think our hospital, I was asked to have it on file at my clinic, but also to have it on file at the hospital, and I think it gets digitized if
Oh,
it's at
okay.
the hospital, so they can pull it up. You
And if
show up in
something
the
happened to
ER, they can pull up your record.
Well, then again, Keith, so if something happens to you somewhere else, and the ER physician there is going to try to get, where
Access
would
your
they go?
records.
Would they go to the hospital, would they go to your primary doc, or where would they go?
Typically, you'd get the records from the doc and the hospital.
And
I
the
mean,
hospital.
that's what I
Okay.
always try to do is, you know, if I'm on the phone with somebody who's traveling through and they have a crisis, then I would get on the phone with their doctor, typically if it's during office hours. And if not, you know, have staff at the hospital contact their hospital
There, yeah.
and try to get whatever records. And, you know, nowadays with electronic medical records, that stuff should be instantaneously available. And it used to be we'd have to fax everything, and
Yeah.
sometimes that would be hours later, but
Yeah, why not just put it on Epic? Doesn't everyone use Epic?
not everybody.
Not every hospital uses Epic?
Well, I mean, again, I've been out of the game for 3 years, so I would love to imagine that every hospital uses the same software, but I can tell you for the last part of my career,
That just
they were
makes
all
everything
kinds of
so
different,
much
there were
easier.
all kinds of different systems, and it was, St. Alphonsus used a totally different system than St. Luke's, and most of our patients went to either St. Alphonsus or St. Luke's, and
Two systems?
and
Two
two,
different
two
systems.
totally different software systems.
I guess
and,
it's all
uh,
about money, right, and marketing.
Well, even when you try to reconcile the systems, because I use my chart, you know, at Winding Waters, and I've got records at a couple of different hospitals, unfortunately. And I keep saying, you know, get the records, and they keep coming back and saying, we'd like to get the records. So the system isn't up to the task either,
Okay.
you know. But if you tell your physician, now, page 29 has these wallet cards. These are really important. And there's 4 of them, and you can make copies and make 8 of them. You know, you can do as many of these as you want. But you can fill these out, put these in your wallet. The information your healthcare providers need in the middle of a crisis will be here. So these are important. That's the second part of the workshop that we do. All these will be filled out. So you'll be ready.
And one thing that I would say that maybe doesn't need to be said, but you can alter these anytime. You can decide to go back and change things. I was surprised that I had patients that would say, well, now that that's all done, doc, am I stuck with that, or can I change my mind? I said, of course you can change your mind. You can just, especially on those worksheets, which I think the worksheets are very important because they provide you with a lot of different nuances to, you know, medical illnesses and what you would do in this or that situation. You can come back and write through it and say, I've changed my mind on this and I don't want that done or whatever. So don't feel like you're stuck. Once you've completed the process, you can always come back and redo it.
Nancy, do you want to start passing that around so we're not
Yes.
bunched up at the end trying to do that?
I,
Lynn, didn't want to come in here today because I was pretty comfortable on the couch. So I went on my chart, and there is a place on there for end of life stuff.
tear out.
Mhm.
So you tear them out, you make a copy, you take it to your primary care, they will scan it in.
Yeah.
And that's probably where it would go.
Okay.
Yeah, and if you revise it, then they're supposed to, invalidate the previous one and put the newest one up. I mean, that's the way it's supposed to work.
But I didn't know if they would check my chart to see if there was anything, like you say, everything gets hectic and all that stuff,
Well, I can tell you that most healthcare providers are trying desperately to get to that information if there's a big crisis. You really want to see the information
You could tell them, couldn't she? Go to my chart, that's
Yeah.
where it is, yeah, okay.
I realized I hadn't done my own, and I started working on it as getting ready for this workshop, and I thought, well, I'll go ahead and do it. I mean, I've been thinking about doing it forever, so I'm going to actually go ahead and do it, and I was working on it, and I got to the part about healthcare representative, and it prompted me actually to call a friend yesterday and say, hey, I'm working on my advanced directive, and I'm wondering, Janet is my healthcare representative, but if she's not available, would you be the alternate? And, the response was kind of like, oh, we don't need to talk about that. So I've got to go back and hammer on them. But I thought, there's a first alternate and a second alternate healthcare representatives, and as far as I'm concerned, the more the better. And it means that you need to discuss it with them. They have to actually sign that they agree to be your healthcare representative. And that's important because these are the people that are going to potentially be in the driver's seat if you're not able to communicate. So.
And these decisions are very important because somebody who doesn't understand what you want feels compelled to do everything they can. Right? So doctors say, well, do you want this or do you want this? The outcome is not, really good, but maybe there's some hope. Well, if you don't know their wishes and they're your beloved or they're, you're going to say, well, you can't really say, I'm not going to go for hope. I'm going to go for practicality. Unless that's spelled out, it's hope. You're in there based on, and getting medical treatment based on someone who loves you, who has hope that the doctors give them a sliver of hope sometimes is just enough to say, go ahead and do it. And then, of course, if they're doing CPR and you're very old, it could crack your ribs, and then you've got more problems.
So, what about, and I everybody here that knows me knows I'm always in a pro group, so I'll bring up that thing. Euthanasia. So what, I just had to put my 19-year-old cat down. I bawled like a baby. It hurt me more than as much as when my daughter died. And I saw him suffering, and I took him in there and made that decision to make sure he didn't suffer. So if you don't want to suffer, is there an option for that you can do, or?
Well, it's not incorporated into the advanced directive, but, euthanasia is technically illegal anywhere in the United States. You can go to Switzerland and be
I
euthanized.
thought it was legal here.
No, that's a hastened death. And, the difference between euthanasia and a physician hastened death is that with euthanasia, the doctor gives you, injects the drug or whatever to actually end your life. And technically, Oregon was the very first state to have what was then called physician-assisted suicide, but we decided that term was not appropriate because this is not like what a person that's depressed and decides to end it all is going through. These are people, and I used to assist people with this. We stopped calling it suicide. We called it a hastened death, a physician-assisted death or a hastened death.
I thought it was
And
death with dignity, no?
that's death with dignity, right? And in that, the way the law reads, the patient is supposed to give themselves the oral medication. Now, there's situations where,
You gotta be awake.
you know, you're skating on a pretty thin edge there, because if the patient has ALS, for example, and you know, Lou Gehrig's disease, and they can't even give themselves
Yeah.
the medication, technically, for the physician to pour the medication down their throat, it's illegal. But, you know, I've assisted numerous patients with it, and it's a good law, but it does require that patients be mentally competent, and they have gone through the process, which is a 2-week process. You've got to make a written request, you've got to make 2 verbal requests, 15 days apart, is the way the Oregon law reads. So typically patients would come to my office, they would say, hey, my cancer's out of control, I'm gonna be, you know, dead in the next 6 months, you've gotta be terminal. And then they would make a request, I would give them the paperwork to do the written request, and then 15 days later, I call them up and say, do you wanna make a second request? And then I can write the prescription for the medication, and the patient is supposed to administer the medication to themselves. But that's a different process than the advanced directive. And
Well, I know a lot of people who give me the medication.
what's that?
I know a lot of people who give me the medication.
That would be wrong.
Yeah.
Might want to not let that be filmed or anything.
So, again, the advanced directive is when you are not able to make decisions for your own health care,
Gotcha, okay.
right? You're just not able because you're not conscious.
Or you're conscious, but you're delirious. I
Right.
mean, you know, I can't go in and ask a patient who's seeing, you know, bugs on the walls and, you know, screaming in fear, well, you know, here, we gotta make a decision now about your health care. They've gotta be mentating normally, and then I would ask them directly. But if you can't communicate or you're out of your head, that's when this would be really useful. Judy?
Having just gone through a medical crisis, and I'm not gonna go on and on about it, but I know it was extremely difficult for our son, our oldest boy, who became the person that had to make the decisions. And it was difficult. My question for you is, though, I was not mentating. I have really no recollection of those first 17 days at St. Luke's. I was unconscious. I don't remember going by ambulance, Rich found me, to the hospital. I don't remember one thing. I was not conscious of being life-flighted to, but I am happy to be alive. So say this would have been found in those first 17 days, and it said, take her off of the ventilator, don't do a tracheotomy, I wouldn't be here. And I'm not, I mean, if I wasn't, because that's kind of my attitude about we die when we die, but I wouldn't have wanted Matt to have to make that kind of decision when I was able then to turn the corner. I don't know how I turned the corner, I have lots of reasons why I think so, but doesn't our physicians have to play some role, and they have to tell the family or tell somebody, well, we should try this first, because I couldn't speak, I had a ventilator.
You know, just to back that up, Judy, I sent out the notice on this meeting, and I got an immediate one back from a friend that some of us know, who said, if I would have been in Judy's shoes, I would have been dead because of my AD.
Yeah.
Perhaps.
Well,
No, he said he would have been.
if you look at the actual advanced
Yeah, I
directive,
haven't-
that legal form, okay,
Yes.
it really only lays out 4 scenarios.
Okay.
It,
In the back.
yeah, at the very back. It only lays out 4 scenarios, and these wouldn't be necessarily the situation you were in. But that's why I think the worksheets are very helpful, because the worksheets provide a lot more context, a lot of different other scenarios. But the actual thing says, it gives 4 scenarios. Close to death. If I'm close to death, then life support would only postpone the moment of my death. You do or don't want tube feeding, you do or don't want life support. Permanently unconscious. If I am unconscious, and it's very unlikely that I will ever become conscious again, you do or don't want life support. If I have a progressive illness that will be fatal and is in an advanced stage, and I am consistently and permanently unable to communicate. I mean, these are pretty extreme terms here.
Yeah.
Consistently and permanently unable to communicate by any means, swallow food and water safely, care for myself, and recognize my family, it's very unlikely my condition will substantially improve. You do or don't want tube feeding and life support, or extraordinary suffering. If life support would not help my medical condition and would make me suffer permanent and severe pain, you do or don't want life support. So those are the 4 conditions that are laid out here in the actual advanced directive. The worksheets give a lot more nuance and a lot more, other scenarios. And so you're right in that the physician should be being able to lay this out for the family or the loved ones and say, yeah, look, she's been in a coma for 2 weeks. Her lungs are whited out on the x-ray and don't look like they're improving at all despite 2 weeks of antibiotics. I don't think
And there's no brain activity.
I don't think she's ever gonna really wake up, and I don't think we're gonna turn this around. Then you would say, well, really, I mean, we're keeping them alive, but there's no real hope for any meaningful recovery. And, or the doctor will come in and say, look, she's showing some response, she's getting better, we're optimistic that she may yet, pull out of this. The doctor is supposed to lay out the context with as much detail as possible for the surrogate decision makers so that they can make a reasonable decision.
That was my question.
Yeah,
But the
and I think
doctor-
it's, go ahead, Judy.
It's just that we're gonna have some medical, because I think after 2 weeks, they weren't so short.
Right.
And there were other times when I did have that CPR, because they had a code, but it was very serious. I'm not saying it's right or wrong, I want to do this, but I do think, I think it's a little, it's just, if I would have done this in April, before I got sick in May, I would have said, oh yeah, if
Well,
I do this, I don't wanna be on a ventilator, but now I'm happy I was on the ventilator, cause I don't even remember
let's
it.
go, I think it's really important to look at this, the
Yes.
sections of this form,
Yes.
because it's not an all or nothing, it's not a, I don't want a ventilator, here's my, decision maker. They lay out scenarios in the brown section, the first in step 1.
Yes,
So if this, then what?
yeah,
And you go through a lot of those, and you do that together as a group. The second section is an individual worksheet. And in those, they have lots of nuances, like Keith was saying. If I have an incurable disease, which, you didn't have,
yeah.
what you went through was curable. So there's ways of really breaking this down into very specific parts. And all of this worksheet will go to whoever's making decisions for you. So they can look at that and say, well, look at what she said here,
Because on page 9, Janet, almost every one of those things, they did.
No, but Judy,
But this part is
That's
that
not- that
cannot
wasn't
be
you.
cured.
That
Well,
wasn't
I
you.
don't know that. I mean, maybe not.
Well, your healthcare provider should be
That's what I'm saying.
should be providing the context.
Yeah.
Look,
Yeah.
if somebody comes in and they've got high blood pressure and they've had diabetes, but they've had a good quality of life, and suddenly they come in respiratory failure from pneumonia.
Yeah.
I always want to try to pull them through it, and I would
Yeah.
convey that to the family. I'd say, look, this is a bad pneumonia, but
We're
they've
gonna
had
try.
a great quality of life, and I think if we give them a few days of intravenous antibiotics, we're going to see which way the wind is blowing. And if they're getting worse and worse and worse and worse and worse and worse and worse, then you know, at some point you can say, well, you know, we've tried and it's not going to work out.
It seemed
But
like that at one point, though, didn't it? That you weren't like
think
getting
so.
better,
They hadn't tried
or
the other antibiotic, they still had another antibiotic, that's what the.
Well, I don't know, I
Yeah,
just,
I
the
don't know.
only reason I bring it up, I don't wanna take up all the time, is just that it is a little tricky.
It's
It's-
very
Well, that's why
tricky.
you need to sit with a
Yeah.
group and a professional and go
That's
through
why
this
I think there's
step by step.
situations, Judy's testimony, bring the group together, cause there's probably stories that we don't
Yeah,
even know that could influence how we're gonna do
Exactly.
this.
Yeah.
And,
'Cause
you know,
she
from
just
my own,
changed my-
Yes.
from my own experience going through it with Janet, we would go through these scenarios. And there were a couple of times I said, well, you know, what if it's not particularly clear? She said, well, you put a note in that says, you know, if it's persisted for, you know, 30 days or more, then consider, or, you know, if it appears there's a fair chance, then consider this. So you can annotate those. And I think it's really helpful to have a professional
Yeah.
who has worked with people at end of life in his career for years and years, plus a mental health person who's trained in how to maybe describe some of those things or annotate it in a way that it'll be understood both by the person who is your your healthcare representative, but also by the doctors.
So when are we gonna have the workshop?
We haven't set a date yet, but, if you sign that sheet, we will put you, we'll create a master list for this group. And Nancy or I or both, will communicate and suggest maybe a couple of dates and see if we can come to some.
So how big a group would you like?
Well, we had 8 before. 8 is fine, but 10 is okay, 12 is okay. Less than 8, probably not.
It's
You
a
know,
good group size. 8, good group size.
Yeah, 8
Yeah.
is a good group size.
It's good.
Yeah, we wanna affect as many people as possible, but, you know, not make it a private,
Would-
private.
You know,
It really
one
should be.
possibility, Janet, would be to have, and we'll help you promote it, okay, from here. So one possibility would be to offer maybe 2 sessions. So, and one, a morning and one an evening, or one, you know, make them distinct enough so people could put a preference, and they could say, I'll do either, but they could put a preference, so, and shoot for 8 or 10,
In each
rather
group.
than try to have one of 15 or something.
Yeah,
You know,
Well, looking from my viewpoint, I mean, I'm retired. People, I don't really have a lot of demands on my time anymore. This is something I have an affinity for because of
yeah.
my career. I'm happy to do it as many times as there is interest. So if we get a big group that sounds like they want to sign up, we'll break it into, 2 groups. And
You'll get over it.
as long as I'm still capable of offering some useful advice, I'm going to be willing to do it. Because when I said that I think I had blanked out a lot of those things after retirement, it's because they were some of the worst times of my career when some patient of mine that I had taken care of for years got gravely ill, and then all the chaos and all the sadness and all the stress, and especially if there's no advance directive and the family is fighting, and every day you're going in and you're trying to sort things out. It's terrible. It's just awful. And I really want to help anybody avoid that if possible. But Judy, you're right. It's never open and shut, and there are always rare exceptions. But a good physician that's been experienced is gonna
No.
get the drift within a fairly short time in most cases. And I think most of us want to avoid unnecessary interventions. If you're really sick and it looks like you're going to die, especially if it is a progressive illness like metastatic cancer.
Yeah.
An acute illness is a different animal because people come down with infections, and
That's right.
you know, we can frequently, not always, turn it around. But if you got kidney cancer and it's spread to the lungs and it's spread, you know, and you can see things winding down, it's like that's when you want to start considering pulling back on interventions. And I've helped a lot of people avoid what would have been a terrible end, because I'd said, really, I mean, you've got all this advanced cancer, you're in pain all the time, you're on a mountain of drugs, your quality of life is lousy, and you want CPR? Why? Because we're just going to break all your ribs. We might keep you alive a little longer, but you know, a cardiac arrest might be the best thing that could happen. So,
Do you feel like it's changing? I mean, what I've heard and read is that, you know, your profession is to keep people alive, right? I mean, doctors, and that often doctors don't even know how to talk about death with their patients. They didn't even learn that in school. So, do you feel like that's changing?
I think it's changed some, but
Yeah.
it's quite true. There are a lot of physicians that just don't even want to discuss it with their
Right.
patients, and they don't ever want to give up. And I mean, I've known some of them, and I don't think they were doing their patients a service
No.
when they were. I mean, I've seen them basically ignore an advance directive and say, "I'm going to do everything I can to keep this patient alive." And that's where your healthcare representative might be able to step in and say, "Hey, doc, I know maybe you don't want to let somebody go, but you know, it looks like to me